Welcome to the Deep Dive, your express route to mastering the core concepts in the texts that truly matter.
Today we're getting into a real cornerstone of medical education.
We're doing a structured analysis of excerpts from the 2017 Grant's Dissector 16th edition.
And this isn't just a manual, it's really an entire educational system.
That's the key point, isn't it?
It is. So our mission here is to give you, the learner, a really comprehensive summary of its philosophy, its techniques, and all the high-yield anatomical insights.
Basically, we're turning this massive volume of information into a focused, powerful study guide.
Exactly. We're dissecting the methodology from the authors Alan J. Dutton and Patrick W. Tank.
And their goal, it seems, is all about clarity. It's about showing how Grant's structures the learning experience to, enhance your spatial understanding.
It's constantly forcing you to link what you see on the surface anatomy and the skeletal landmarks, to the deep, soft tissues you need to find.
To isolate and identify.
Precisely. Because that anatomical knowledge isn't static, it's three-dimensional, and it requires this constant correlation.
So where do we start?
I think we have to start with the book's organizational architecture. It really dictates how everything flows in the lab.
Okay, so the 16th edition, it uses this modified unit organization, and it's incredibly consistent.
Super consistent. Every single dissection unit follows this standard template.
We start with a title, then there's a critical overview, then the step-by-step instructions, and finally a dissection follow-up section.
And that dissection overview part, that marks a fascinating pedagogical shift.
How so?
Well, in earlier editions, that section might have just been, say, a bulleted list.
Okay.
Now, it integrates these mandatory numbered steps for surface anatomy and osteology.
So you have to do that first.
You have to. It ensures you successfully identify the skeletal and surface landmarks before you even think about working on the soft tissue.
That structural requirement, it forces you to solve the spatial reasoning puzzle before you even cut.
Exactly. And this ties directly into the book's core philosophy, which it requires us to redefine a key verb, dissect.
Which most people think of as to cut apart.
Right. But Grant's defines it as to tear apart or separate.
So the primary technique throughout the entire manual has to be blunt dissection.
That's the mandate.
So if the definition is tearing apart, then the scalpel, the most iconic surgical tool, is deliberately sidelined.
It is. The scalpel is primarily recommended for only two things. First, the initial skin incisions.
Acting like a skinning tool.
Pretty much.
Yeah.
And second, if you absolutely have to, for crude cuts on extremely tough, dense connective tissue.
But not for general dissection.
It's strongly discouraged. It gives you almost no tactile feedback, which means you can sever a critical nerve or vessel before you even feel the resistance.
Which makes your choice of other tools absolutely paramount. So let's review the essential toolkit the manual requires and how each tool supports that blunt dissection philosophy.
Okay, let's start with the probe. This is, I would argue, the most essential instrument.
The most important one.
Yes. It's an excellent blunt tool designed to gently tear connective tissue and, crucially, allow you to feel the difference between tough fascia and delicate neurovascular structures before you damage them.
It's like a sensory extension of your fingers.
It is.
Okay, what about grasping instruments?
You need at least 2 pairs of forceps. One pair should have blunt corrugated tips. That's for general lifting and handling without causing damage.
And the second pair?
The second must be tissue forceps, what we often call rat-toothed tips. They're specifically for getting a firm grip on tougher structures or handling the skin flaps.
And then there's the hemostat, the powerful third option. What's its main use and what's the big caveat?
So the hemostat is a strong, locking, grasping tool. It's perfect for handling slippery things like skin during reflection.
Or for clamping tough tissue.
Right, but its disadvantage is huge.
Yeah.
It crushes delicate structures. It doesn't discriminate.
So it's a tool of brute force, not precision.
Yeah.
Now, before anyone even touches a specimen, the book lays out some mandatory protocols for safety and care. What are the must-dos?
For safety, it's standard lab protocol. You have to wear scrubs or a long lab coat or apron.
And that outer layer never leaves the lab.
Absolutely not. You don't want to carry contamination outside. And of course, no open-toed shoes. That protects you from drop sharps or chemical spills.
And for the specimen itself.
The care is crucial. The cadaver must be kept moist all the time using the wetting solution. Grant's is very emphatic on this point. Desiccated parts cannot be restored.
And that permanently compromises the learning experience.
Completely.
Okay, so since accuracy and prep are everything, let's see how this precision-focused methodology applies to regional anatomy. Let's start with the back.
Right. The first layer you encounter involves 5 key superficial muscles you have to locate: the trapezius, latissimus dorsi, the rhomboid major and minor, and the levator scapulae.
And these all connect the upper limb and scapula to the axial skeleton.
They do. And linking this back to the osteology that's mandated in the overview, proper vertebral identification is just fundamental.
You're taught to find C7, the vertebra prominence.
Because its spinous process is usually the most prominent one in the cervical region. It's your starting landmark.
And we also need to be able to tell the different vertebral types apart.
Yes. If we contrast the thoracic and lumbar vertebrae, for instance, there's a key difference in their spinous processes.
Lumbar vertebrae have those much larger bodies for weight bearing.
Right, and they have broad spinous processes that project straight back, and importantly, they do not overlap.
And that lack of overlap is what gives the lumbar spine its greater range of flexion and extension.
It is. Unlike the thoracic spine where they're arranged like shingles on a roof, which really restricts movement.
Okay, moving to a more complex region, the 16th edition made some strategic modifications for the head dissection.
Yes, to acknowledge student time constraints. The new approach advises maintaining the superficial anatomy, like your facial nerves and vessels on one side of the head, for reference.
So you leave one side intact.
You do, and then you perform all the deeper, more destructive dissections exclusively on the other, the contralateral side.
That is a brilliant adaptation. It preserves a teaching reference while still letting you get into those tricky, deep spaces.
It is. Specifically, they made modifications to the cuts through the calvaria, the skull cap, and the mandible.
And these changes simplify and speed up access to what exactly?
To deep structures, particularly the infratemporal fossa, that's the deep space below the temporal bone and behind the mandible, and the internal features of the cranial cavity.
That focus on pedagogical flexibility, it seems to continue right into the trunk. When we look at the massive abdominal wall dissection, Grants actually offers a choice,
It does. It includes alternative dissection instructions.
recognizing different teaching styles.
Right. So the students or the faculty can choose to reflect the abdominal wall using either a conservative quadrant approach,
Which keeps more tissue intact for later.
or they can reflect the entire abdominal wall, which gives you maximum exposure right up front.
Let's move superiorly now to the thorax and focus on the clinical anatomy of the female breast. It's a modified sweat gland contained within the superficial fascia.
And its boundaries extend from the sternum all the way to the mid-maxillary line and roughly from rib 2 down to rib 6.
The clinical relevance here is highest in the superolateral quadrant.
Absolutely. This area has the highest concentration of glandular tissue, so it's the most common site for breast cancers.
And you often see an axillary tail of that tissue extending from this quadrant right into the axilla.
You do. And clinically, when a tumor advances into the deeper structures, that's when you start to see visible signs that we have to recognize.
Right.
If the tumor invades the underlying pectoral fascia, it can cause traction on the suspensory ligaments,
And that results in that classic skin dimpling or tethering.
the orange peel appearance. And in the most advanced stages, you can get fusion to the chest wall, which restricts mobility.
This is where the methodology of Grants truly pays off. Let's tackle the high-yield learning area in the axilla and the neurovasculature of the upper limb.
Okay, this is a major exam spot. The relationship between the neurovascular bundle is highly specific.
So important to get right.
It is. When you're isolating the third part of the axillary artery, you locate the 3 terminal branches of the brachial plexus.
The musculocutaneous, the median, and the ulnar nerves.
Then together, they form this very distinctive letter M that's positioned immediately anterior to that section of the artery.
That visualization is a fantastic mnemonic for structures you absolutely cannot sever.
This is a lifesaver.
And speaking of structures you cannot sever, let's discuss the single most vulnerable nerve in the hand, the recurrent branch of the median nerve.
Yes. This structure has earned the nickname the $1 million nerve in clinical circles.
And why is that?
Because it is exceptionally superficial. It crosses right over the thenar eminence. A seemingly minor cut over the thumb pad can easily sever this nerve.
And that leads to paralysis of the thenar muscles.
The muscles responsible for opposing the thumb, it results in a massive functional loss.
That just perfectly illustrates why that probe first, scalpel last philosophy is so critical in these distal, delicate areas.
It really does.
Okay, let's return to the trunk and look at some clinical vascular backup systems, specifically the epigastric anastomoses within the rectus sheath.
This is a really robust collateral system. You have the superior epigastric vessels, which descend from the subclavian system,
Right.
and they anastomose with the inferior epigastric vessels, which are ascending from the external iliac system. This forms a continuous, crucial channel.
So what's the clinical payout of this connection?
It provides two critical circulatory backup roles. First, it acts as a collateral venous channel. It can drain blood superiorly into the superior vena cava if the inferior vena cava is obstructed.
A vital detour.
And second, on the arterial side, it can provide crucial collateral blood supply to the lower body if the main abdominal aorta is slowly occluded. It keeps the circulation going when the main pipelines are blocked.
Next, let's organize our knowledge of the peritoneal cavity. We need to quickly define the two organ types based on their relationship with the peritoneum.
Right, so we distinguish between intraperitoneal organs, which are suspended within the peritoneal cavity by a mesentery.
Like the stomach, spleen, liver, jejunum, transverse, and sigmoid colon.
Exactly, and then the retroperitoneal organs, which lie behind it.
And when you're navigating this cavity, you have to know the omental foramen. It's the narrow passage connecting the greater peritoneal sac to the lesser sac, also called the omental bursa.
Mm-hmm.
So what forms the crucial anterior boundary of this foramen?
The anterior boundary is the hepatoduodenal ligament, and this structure is surgically critical
Why is that?
because it contains the three major components of the portal triad: the hepatic portal vein, the hepatic artery proper, and the common bile duct. If you clamp this ligament during surgery, you temporarily control all inflow to the liver.
Wow.
It's a key surgical maneuver.
Finally, let's finish with a clinically high-stakes contrast. The lymphatic drainage of the male genitalia. This is vital for diagnosing metastatic disease.
This point is so often missed, and it carries huge clinical weight. The lymphatics from the scrotum, that's the outer skin and superficial structures, they drain conventionally to the superficial inguinal lymph nodes in the groin.
Okay, that makes sense.
But, and this is the key, the lymphatics from the testes itself, because of its embryological origin high up in the abdomen, they follow the testicular vessels back through the deep inguinal ring.
And where do they end up?
They bypass the entire pelvic system and drain directly into the deep abdominal nodes, the lumbar or lateral aortic and preaortic lymph nodes.
So what does that mean for diagnosis?
It means when you're diagnosing metastasis from a testicular tumor, you have to primarily focus your imaging and palpation deep in the abdomen, not just in the groin.
An anatomical difference based entirely on embryological descent.
Exactly.
And that is the level of foundational knowledge that Grant's Dissector aims to build.
It is.
What stands out most to me is the book's commitment to prioritizing efficiency and high-stakes clinical anatomy.
From the organized unit structure emphasizing osteology, to the technique modifications for the head, to the detailed exploration of neurovascular vulnerability.
It really is a methodology, not just a list of steps.
It emphasizes synthesis over just brute memorization.
I think we've covered the critical fact that dissection means separation, using a probe for that tactile feedback.
And we've highlighted the extreme vulnerability of structures like that million-dollar nerve.
Which leads us to our final provocative thought for you to consider as you internalize this material. Think about the tension between speed and safety in the lab.
Considering the delicate nature of the recurrent branch of the median nerve, that million-dollar nerve, and the essential role of the probe for blunt dissection.
Here's the question. If you were advising a first-year medical student, what single dissection technique or tool handling practice would you prioritize to minimize injury to delicate neurovascular structures, and why?
Think about the practical application of blunt separation versus the inherent risk of cutting.
Something to mull or explore on your own. We hope this deep dive into the methodology and anatomy of Grant's Dissector serves as a high-value preparation for your lab experience.
Until our next exploration.